Hello, this is Dr. Alex Vasquez. What I'm going to do in this very brief and very fast video is discuss some of the objective, real, non-neurologic, non-psychiatric abnormalities seen in patients who have fibromyalgia. This is part two of my argument against the concept of primary central sensitization as the underlying cause of fibromyalgia. Fibromyalgia is often described as a disorder of central sensitization, and many authors and doctors have been led to believe that the primary problem in fibromyalgia patients is that their nervous systems have just become too sensitive to pain. I believe that this is inaccurate, although I do recognize that central sensitization exists and that it probably has some role in fibromyalgia. I just don't believe it should be represented as the primary underlying problem. So let's describe fibromyalgia very quickly, and then we'll go through the controversy and some research and discuss some responsibilities here. Fibromyalgia is commonly described as an idiopathic syndrome, which is incorrect. Commonly described as an idiopathic syndrome, principally characterized by widespread body pain and numerous myofascial tender points at specific locations. Controversy is that some researchers and authors write that fibromyalgia is due to central sensitization or the amplification of pain reception or pain perception, and that the condition therefore needs to be treated indefinitely with pain-relieving drugs. This approach does not address the underlying problems and forces patients to remain drug-dependent indefinitely. The facts from the research show that fibromyalgia is an organic disease, not simply a pain syndrome. I think that this means that doctors and medical journals have the responsibility to take the condition seriously and to treat the underlying causes rather than simply treating the pain while allowing the disease to persist. Objective abnormalities seen in patients with so-called fibromyalgia syndrome include disorganization of actin filaments within their muscle tissues, accumulation of lipofuscin bodies consistent with premature muscle aging, increased DNA fragmentation, focal areas of chronic muscle contraction, and reduced perfusion of muscle tissue during exercise. Some of the mitochondrial defects seen in patients with fibromyalgia include accumulation of glycogen and lipid consistent with mitochondrial impairment, significant reductions in the number of mitochondria, reduced activity of certain energy or ATP producing enzymes such as citrate synthase, cytochrome oxidase. These patients often have nutritional deficiencies, including antioxidants such as CoQ10. This promotes mitochondrial dysfunction and therefore promotes a phenomenon called mitophagy, which results in reduced numbers of mitochondria, and this perpetuates, of course, the muscle pain, fatigue, and neurocognitive dysfunction seen in these patients. Furthermore, it also exacerbates the reactive oxygen species production or free radical production by the mitochondria, and this further depletes nutrient levels and CoQ10 levels in particular. CoQ10 deficiency is common in these patients, and it has a pathologic role in the disease process. It contributes to and is caused by the oxidative stress, which is noted in these patients as well. Patients with fibromyalgia are also noted to have HPA disturbance. That stands for hypothalamic pituitary disturbance. They have low-grade immune activation. This is also seen in patients with the related syndrome, irritable bowel syndrome. These patients generally have some degree of bacterial overgrowth of the small bowel, or what we call small intestine bacterial overgrowth. This is evidenced by not only some microbiologic studies that have been performed, for example, in patients with chronic fatigue syndrome, but more specifically in patients with fibromyalgia. They often have abnormalities on breath lactulose testing or breath hydrogen and methane testing. These patients often have vitamin D deficiency. In some patients, the vitamin D deficiency mimics fibromyalgia, but vitamin D deficiency is not the cause of fibromyalgia. Other studies have shown consistently that these patients have low levels of L-tryptophan. This is probably secondary to the bacterial overgrowth of the small bowel due to bacterial production of the enzyme tryptophanase. In this diagram, or histologic illustration from the journal Annals of Rheumatic Disease in 2004, what we see here is a comparison between healthy muscle tissue and abnormal muscle tissue seen in patients with fibromyalgia. What we see in patients with fibromyalgia is glycogen accumulation, which indicates that their muscles are not able to process or metabolize fuel sources very efficiently. This points directly to mitochondrial impairment, which is consistently noted as one of the underlying problems within fibromyalgia. Now, it's not the cause of the condition. It's the cause of perhaps the pain and the muscle fatigue and weakness, but something has to be causing the mitochondrial dysfunction, and as I've represented before, that's generally dysbiosis. What else do we see in abnormal muscle tissues from patients with fibromyalgia? Accumulation of glycogen, enlargement and different shape of mitochondria. This is also consistent with mitochondrial impairment and what we might describe generally as a mitochondrial myopathy. In this case, it's an acquired mitochondrial myopathy due to microbial dysbiosis. Here's another quick list of abnormalities seen in muscle biopsies from patients with fibromyalgia. These patients show defects in mitochondrial structure and function, reduced numbers of capillaries and skeletal muscle, thickened capillary endothelium, which results in hypoxia, so to speak, of the muscle tissue, ragged red fibers consistent with the development of mitochondrial myopathy, rubber band morphology in their muscle tissue, and reticular threads due to prolonged muscle contraction, disorganization of actin filaments, as I mentioned before, accumulation of lipofuscin bodies consistent with premature muscle aging, accumulation of glycogen and lipid accumulation consistent with mitochondrial impairment, significant reductions in the number of mitochondria. Again, this goes back to the phenomenon known as mitophagy, which is the actual engulfment and destruction of mitochondria due to mitochondrial impairment, increased DNA fragmentation, and again, focal areas of chronic muscle contraction. Biochemical abnormalities seen in patients with fibromyalgia include reduced activity of citrate synthase and cytochrome oxidase. These are enzymes and pathways involved with ATP production within the mitochondria. Intracellular magnesium levels are reduced, and complex ATP magnesium is reduced by 12%. Magnesium deficiency actually promotes hypersensitivity to pain due to a reduction in partial blockade of the NMDA neurotransmitter receptor. There's also increased oxidative stress seen in patients with fibromyalgia. As I mentioned before, this causes antioxidant nutrient depletion and can, of course, be caused by antioxidant nutrient depletion. So these patients enter into a vicious cycle of oxidative stress and progressive nutrient depletion. There's evidence of hypothalamic pituitary adrenal disturbance and increased cytokine production, especially interleukin-6. This promotes the central sensitization, hyperalgesia, fatigue, and depression. Most of these patients, as I mentioned before, have some evidence of bacterial overgrowth of the small bowel. And again, vitamin D deficiency is very common in patients with fibromyalgia, but it's not the cause of fibromyalgia. This page lists some of the citations that I have used previously for the development of this presentation. So based on all the abnormalities that I previously mentioned, we can form an integrated model of fibromyalgia and therefore help to not only understand the condition but actually treat the condition as well. This is a diagram from my book which focuses on bacterial overgrowth of the small bowel, nutrient deficiencies such as L-tryptophan, CoQ10, and other antioxidants, including melatonin for that matter, which is an endogenous hormone which promotes sleep, but it also has an important role in the protection of mitochondrial function due to its antioxidant effect. These patients often have chemical sensitivity, which could be caused by exposure to bacterial lipopolysaccharide, which inhibits the cytochrome P450 pathway in the liver, therefore promoting the accumulation of xenobiotics, which therefore promotes sensitization to those xenobiotics, which is why these patients often have so-called environmental intolerance or multiple chemical sensitivity. All of these and more considerations have been discussed in one of my more recent books called Migraine Headaches, Hypothyroidism, and Fibromyalgia. I've also reviewed this along with several other topics in another book, also updated in 2012, called Integrative Orthopedics. This is the third edition of the textbook. Both of these books are available from Amazon.com and Amazon's publisher, CreateSpace.com. You're welcome to access these if you have more interest in these topics. Thank you very much. This has been Dr. Alex Vasquez reviewing some of the objective abnormalities seen in patients with fibromyalgia. And again, this argues against primary central sensitization as the cause of fibromyalgia. Fibromyalgia cannot be attributed to primary central sensitization with all of these other abnormalities being documented. So we need to have a more complete understanding of this condition, and this is what I've discussed in several of my publications. Thank you.